Inguinal hernias. Welcome to today's podcast, where we discuss the management of inguinal hernias. Our conversation is structured in a question and answer format to support medical students, surgical residents, clinicians, and all listeners interested in the care of inguinal hernias. Pause the podcast after each question to attempt answer. Let's begin. Introduction question. How common is inguinal hernia repair worldwide? Answer. It is one of the most common surgical procedures globally, with more than 20 million operations performed each year. Question. What are the recurrence rates after inguinal hernia repair? Answer. Despite advances in technique, recurrence ranges from 1.7% to 10%, and about 10% to 15% of patients require repeat operation. Question. How often do patients experience pain after inguinal hernia surgery? Answer. About 10% to 12% of patients report ongoing pain, and about 1% to 3% have severe, persistent pain. Question. Which groin hernia types are most common? Answer. Inguinal hernias, including direct and indirect types, are more common than femoral hernias, and indirect inguinal hernias are the most prevalent type in both males and females. Question. How does the incidence of inguinal hernia differ between males and females? Answer. Inguinal hernias are much more common in males, affecting about 27% to 43%, compared with about 3% to 6% in females. Question. What are key characteristics of femoral hernias? Answer. Femoral hernias are less common, occur more often in females with an approximately 10 to 1 female to male ratio, and are frequently misdiagnosed. Pertinent anatomy question. How do surgical approaches relate to anterior and posterior anatomy in inguinal hernia repair? Answer. Open techniques are generally associated with anterior approaches, while minimally invasive methods often use posterior approaches. Question. Why is understanding inguinal anatomy from both anterior and posterior perspectives important? Answer. A comprehensive understanding from both viewpoints is crucial for safe dissection and effective repair. Anterior anatomy, internal oblique muscle and aponeurosis. Question. Which superficial blood vessels may be ligated to improve operative exposure? Answer. The superficial circumflex iliac vessels, superficial epigastric vessels, and external pudendal vessels can be ligated when needed for exposure. Question. What is the role of the external oblique muscle in the inguinal region? Answer. It is the most superficial lateral abdominal wall muscle, and its aponeurosis forms the superficial boundary of the inguinal canal. Question. How is the inguinal ligament formed and where does it attach? Answer. It is formed by the inferior edge of the external oblique aponeurosis, extends from the anterior superior iliac spine to the pubic tubercle, and has a medial extension called the lacunar ligament. Internal oblique muscle and aponeurosis. Question. Where is the internal oblique muscle located and how do its fibers run? Answer. It is the middle layer of the lateral abdominal wall. Its fibers run superiorly and laterally in the upper abdomen and run inferiorly in the inguinal region. Question. When does the conjoint tendon form and where is it most evident? Answer. In about 5% of cases, the aponeuroses of the internal oblique and transversus abdominis muscles join to form the conjoint tendon, which is most evident at the pubic tubercle. Question. How do internal oblique muscle fibers relate to the cremaster muscle? Answer. Internal oblique fibers continue inferiorly to become cremaster muscle fibers, which encircle the spermatic cord and attach to the tunica vaginalis of the testis. Transversus abdominis muscle and aponeurosis and transversalis fascia. Question. What is the course of the transversus abdominis muscle, particularly in the inguinal region? Answer. The transversus abdominis muscle runs transversely throughout the abdomen, but its fibers are slightly oblique and downward in the inguinal region. Question. What surfaces does the aponeurosis of the transversus abdominis cover? Answer. The aponeurosis of the transversus abdominis covers both the anterior and posterior surfaces of the abdominal wall. Question. How is the iliopubic tract formed? Answer. The transversalis fascia and the aponeurosis and fascia of the transversus abdominis condense to form the iliopubic tract. Inguinal canal. Question. Where is the inguinal canal located and what does it connect? Answer. It is located cephalad to the inguinal ligament and extends between the internal inguinal ring and the external inguinal ring. Question. What are the main borders of the inguinal canal? Answer. The superficial border is formed by the external oblique aponeurosis, and the floor is formed by the transversus abdominis muscle and the transversalis fascia. Question. How are the cephalad and inferior walls of the inguinal canal formed? Answer. The cephalad wall is formed by the musculoponeurotic arches of the internal oblique and transversus abdominis muscles, and the inferior wall is formed by the inguinal ligament and lacunar ligament. Question. What are the borders of Hesselbach's triangle? Answer. Its borders are the inferior epigastric vessel superolaterally, the rectus sheath medially, and the inguinal ligament and pectineal ligament inferiorly. Question. What does Hesselbach's triangle refer to in relation to the inguinal canal? Answer. It refers to the margins of the floor of the inguinal canal. Question. What structures pass through the inguinal canal in males and females? Answer. In males, the inguinal canal contains the spermatic cord, including cremaster muscle fibers, the vas deferens, testicular vessels, the genital branch of the genitofemoral nerve, lymphatics, and the processus vaginalis. In females, it contains the round ligament. Question. Which nerves are commonly exposed during inguinal hernia surgery? Answer. The iliohypogastric nerve, ilioinguinal nerve, and genital branch of the genitofemoral nerve are commonly exposed. Question. What areas do the iliohypogastric and ilioinguinal nerves supply sensation to? Answer. They provide sensation to the groin, the base of the penis, and the upper medial thigh. Question. What is the function of the genital branch of the genitofemoral nerve? Answer. It innervates the cremaster muscle and provides sensory innervation to the lateral scrotum and labia. Posterior anatomy. The myopectineal orifice. Question. Where is the myopectineal orifice located? Answer. It is located on the medial aspect of the superior gap between the pelvis and the thigh. Question. Why is the myopectineal orifice significant in the development and repair of groin hernias? Answer. Weakness of the myopectineal orifice can lead to hernias in the inguinal region, and modern hernia repair is founded on wide reinforcement of this orifice. Femoral and iliopectineal area. Question. Where is the inguinal ligament located? Answer. It is the inferior border of the external oblique muscle, extending from the pubic tubercle to the anterior superior iliac spine. Question. What is the function of the inguinal ligament in dividing the space below it? Answer. It divides the space below it into two compartments, a medial vascular space and a lateral muscular space. Question. What is the iliopectineal arch and what does it separate? Answer. It is a condensation of the iliopsoas fascia that separates the vascular and muscular vascular compartments below the inguinal ligament. Question. Which muscles form the iliopsoas complex and where does their common tendon insert? Answer. The iliacus and psoas major muscles form the iliopsoas complex and share a common tendon that inserts on the femur. Question. Where does the femoral nerve travel in relation to the psoas muscle and inguinal ligament? Answer. It runs deep within the psoas muscle, emerges laterally, and passes beneath the inguinal ligament. Question. What is the course of the lateral femoral cutaneous nerve and what injury can it cause? Answer. It exits from the lateral border of the psoas muscle, travels over the iliacus muscle, and can be injured, causing neuralgia paresthetica. Question. What is the function of the iliopsoas fascia during hernia repair? Answer. It protects surrounding nerves and should be preserved during hernia repair. Question. Where is the pectineus muscle located in relation to the vascular gap? Answer. It covers the floor of the vascular gap. Question. Where does the pectineus muscle insert? Answer. It inserts into the pectineal line via the pectineal ligament, also called Cooper's ligament. Question. Where is the obturator foramen located and what passes through it? Answer. It is located posterior to the pubic arch, between the pubic bone and the ischium, and it allows the obturator muscle and associated neurovascular structures to pass through. Question. How do the major vessels change name as they pass beneath the inguinal ligament? Answer. The external iliac artery and vein pass beneath the inguinal ligament and continue as the femoral artery and vein. Question. Where is the femoral canal located, and how is the lacunar ligament formed? Answer. The femoral canal is a recess of the transversalis fascia located anterior to the femoral vein. The lacunar ligament is formed by the medial aspect of the inguinal ligament inserting into the pectineal rim. Question. Are the inguinal ligament and lacunar ligament visible from the posterior wall? Answer. Yes, they are visible from the posterior wall. Question. How is the inguinal canal formed relative to the inguinal ligament? Answer. It is formed by the transversalis fascia and runs parallel and posterior to the inguinal ligament. Question. How can a large femoral hernia affect typical anatomy? Answer. A sizable femoral hernia extending medially can alter the usual anatomical relationships. Question. How does the inguinal ligament extend in the posterior view? Answer. It extends from the iliopectineal fascia to the pubic tubercle. Question. What forms the medial border of the femoral canal? Answer. The medial extension of the inguinal ligament forms the medial border of the femoral canal. Question. How does the space between the inguinal ligament and its medial extension relate to the inguinal canal and femoral canal? Answer. The space between the inguinal ligament and its medial extension serves as the floor of the inguinal canal and the ceiling of the femoral canal. Medial supporting structures of the posterior wall. Question. Where does the linea alba terminate and what structure is found at its pubic end? Answer. It ends at the pubic area with a triangular structure called the adminiculum. Question. Where does the rectus abdominis muscle insert inferiorly? Answer. It inserts via a significant tendon inferiorly into the pubic rim. Question. Where does the internal oblique muscle arise and where does it contribute in the lower abdomen? Answer. It arises laterally from the iliopsoas fascia, fans out inferiorly, and reinforces the anterior rectus sheath. Question. Where is the transversus abdominis located relative to the internal oblique at this level? Answer. It is posterior to the internal oblique muscle and is mostly aponeurotic at this level. Question. How is the falx inguinalis formed? Answer. It is the arch formed by the internal oblique and transversus abdominis muscles. Question. How is the conjoint tendon formed and where does it insert? Answer. In about 5% of patients, the middle tendon of the transversus abdominis joins the tendon of the internal oblique to form the conjoint tendon, which inserts into the pubis. Question. Where is the external oblique muscle aponeurotic in the inguinal region? Answer. It is aponeurotic in the medial inguinal area. Question. What is the function of the external oblique muscle in relation to the inguinal canal? Answer. It covers the anterior inguinal canal and forms the external inguinal ring. Question. How is the inguinal ligament related to the external oblique muscle? Answer. It forms the inferior border of the external oblique muscle. Question. Where is the arcuate line located? Answer. It is located about 1/3 of the distance between the umbilicus and the pubis. Question. What is another name for the arcuate line? Answer. It is also called the semicircular line of Douglas. Question. How does the arcuate line relate to the rectus abdominis muscle? Answer. The posterior sheath of the rectus abdominis muscle classically ends at the arcuate line. Question. Where does the inguinal canal extend in this description? Answer. It extends from the anterior superior iliac spine to the pubis. Question. What is Hesselbach's ligament? Answer. It is a facial condensation that reinforces the posterior wall of the inguinal canal and splits it into medial and lateral portions. Question. What is the function of Hesselbach's ligament? Answer. It supports the epigastric vessels. Question. Where is the corona mortis located and what vessels does it connect? Answer. Accessory obturator veins and arteries cross the pubic rim, connecting the obturator vessels with the epigastric vessels. Question. What branches are described for the corona mortis? Answer. Superior and inferior ramus branches are described. Question. Why is careful dissection important around the corona mortis? Answer. Careful dissection is crucial to prevent bleeding due to the crown of death vascular configuration. Question. What causes a direct hernia in this context? Answer. It is caused by weakness of the transversalis fascia and by absence or displacement of supporting structures of the posterior wall. Question. Where is a direct hernia typically located in relation to the epigastric vessels? Answer. It is typically medial to the epigastric vessels within Hesselbach's triangle, but it can also appear lateral to the epigastric vessels. Question. Which supporting structures are listed for the posterior wall in this description? Answer. The listed supporting structures are Hesselbach's ligament, the conjoint tendon, and Henel's ligament, the internal ring and the cord elements. Question. What is the transversalis sling and why is it an important landmark? Answer. It is a condensation of the transversus abdominis aponeurosis and transversalis fascia, and it serves as an important landmark during minimally invasive inguinal hernia repair. Question. How is the internal ring formed in males and females? Answer. In males, the gubernaculum testis pulls the vas deferens and internal spermatic vessels into the internal ring. In females, the round ligament, which is analogous to the gubernaculum, enters the internal ring and inserts into the labia majora. Question. What pathway do the cord elements follow before entering the inguinal canal? Answer. The cord elements pass through the transversalis sling before entering the inguinal canal. Question. What is the pathway of the genital branch described here? Answer. It runs parallel to the iliac artery, passes under the inguinal ligament, and enters the inguinal canal. Question. What is the pathway of the femoral branch described here? Answer. It runs laterally and courses under the inguinal ligament. Question. What sensory function is attributed to this nerve in the description? Answer. It provides sensory innervation to the anteromedial thigh. Question. Where is an inguinal canal lipoma located relative to the cord elements and transversalis fascia? Answer. It is anterolateral to the cord elements and above the horizontal limb of the transversalis fascia. Question. How does an inguinal canal lipoma appear compared with lymph nodes? Answer. It is lighter in color than lymph nodes. Nerve distribution question. How can lipomas be distinguished from a fatty spermatic cord during examination? Answer. Retracting the suspected lipoma laterally and the cord elements medially can help differentiate lipomas from a fatty spermatic cord. Question. What anatomical considerations are important for preventing nerve injury in the posterior wall? Answer. Understanding nerve distribution in the posterior wall is crucial for preventing nerve injury. Question. What facial coverage considerations are important for nerve preservation? Answer. Awareness of somatic and autonomic neural structures and their facial coverings is vital for nerve preservation. Question. Where is the triangle of pain located? Answer. It is a trapezoidal or triangular region in the posterior inguinal wall that is medial and inferior to the inguinal ligament and iliopubic tract and lateral to the spermatic vessels. Question. What dissection cautions apply in the triangle of pain? Answer. Avoid mechanical fixation or careless dissection in the triangle of pain to prevent nerve injury. Question. What is the function of the pyravasal nerves? Answer. Pyravasal nerves provide autonomic innervation to the testicle. Question. Where do the pyravasal nerves originate and how do they reach the testicle? Answer. These nerves originate from the pelvic and hypogastric plexi and travel along the vas deferens to reach the testicle. Question. What can happen if pyravasal nerves are injured? Answer. Damage to these nerves can cause deep testicular visceral pain, the umbilical vesicle fascia and associated microfascia. Question. How should the triangle of pain be expanded for safer planning? Answer. Extend the superolateral border 2 cm above an imaginary line between the anterior superior iliac spine and the internal inguinal ring. Question. Where is the umbilical vesicle fascia located and what does it contain? Answer. It surrounds the bladder and contains the bladder blood supply and autonomic innervation. Question. What is the anterior relation of the umbilical vesicle fascia? Answer. Its anterior relation is the prevesical space, also called the space of Retzius. Question. What is the function of the umbilical vesicle fascia in compartmental anatomy? Answer. It divides the medial compartment from the lateral compartment. Question. Why is careful division of the umbilical vesicle fascia surgically important? Answer. Careful division is essential for achieving a critical view of the myopectineal orifice during minimally invasive inguinal hernia repair. Question. What is the origin of the umbilical vesicle fascia? Answer. It is an extension of the posterior rectus sheath. Management of inguinal hernias diagnosis question. What should preoperative assessment include for suspected inguinal hernias? Answer. A comprehensive history and physical examination are crucial to evaluate risk factors, symptoms, and surgical history. Question. How does prior surgical history affect the choice of approach for inguinal hernia repair? Answer. Prior abdominal or pelvic surgeries, especially prior hernia repairs, influence whether a minimally invasive preperitoneal approach or an open anterior approach is most appropriate. Question. Why is it important to obtain and review prior operative reports? Answer. Reviewing previous operative reports, especially those related to hernia repairs, is essential for understanding anatomical variations in the presence of implants. Question. How is groin hernia diagnosis recommended to be performed on clinical examination? Answer. Clinical examination in standing and supine positions is recommended. Question. How can the Valsalva maneuver help in diagnosing a groin hernia? Answer. It can aid in diagnosing hernias when no obvious bulge is present. Question. When should a femoral hernia be suspected on examination? Answer. A femoral hernia is suspected if a bulge is found below the inguinal ligament. Treatment non-operative management question. Which imaging modality is useful for vague groin swelling or occult hernias? Answer. Ultrasound is useful for vague groin swelling or occult hernias. Question. Which imaging modality is useful when ultrasound is negative or non-diagnostic? Answer. Computed tomography or dynamic magnetic resonance imaging is useful when ultrasound is negative or non-diagnostic. Question. When may imaging be useful for suspected recurrence or massive scrotal hernias? Answer. Imaging may be useful for recurrence or massive scrotal hernias. Question. What is the typical treatment recommendation for a symptomatic groin hernia? Answer. Operative repair is typically recommended due to the natural progression of groin hernias. Question. What study limitations are noted for non-operative management evidence? Answer. The results are not applicable to females or femoral hernias, which have a higher risk of strangulation. Question. What symptom management options are mentioned for patients choosing non-operative management? Answer. Hernia trusses may provide symptomatic relief for patients choosing non-operative management. Operative management. Open techniques question. What is meant by anterior approaches in open operative management? Answer. Anterior approaches are open techniques that access the inguinal region from the front of the abdominal wall. Question. What is the most common hernia repair technique used for inguinal hernias globally? Answer. Anterior hernia repairs are the most common technique for inguinal hernias globally. Question. What repair method is considered current best practice for open inguinal hernia repair? Answer. Tension-free repairs are the current best practice. Question. When are mesh prostheses generally used, and when might they be avoided? Answer. Mesh prostheses are generally used, except in cases of contamination or concurrent bowel resection. Question. Where is the incision typically placed for an open anterior inguinal hernia repair? Answer. A transverse or slightly curved incision is made just above the inguinal ligament and about a finger breadth below the internal inguinal ring. Question. Where is the internal inguinal ring located on the body surface? Answer. It is located midway between the anterior superior iliac spine and the pubic tubercle on the same side. Question. How does dissection proceed in an open anterior inguinal hernia repair? Answer. Dissection proceeds through the subcutaneous tissues and scarpus fascia. fascia. Question. What is done to the external oblique fascia to expose the inguinal canal during an open repair? Answer. The external oblique fascia is incised through the superficial inguinal ring to expose the inguinal canal. Question. Which nerve should be carefully identified and handled during open inguinal hernia repair to prevent damage? Answer. The ilioinguinal nerve, iliohypogastric nerve, and genital branch of the genitofemoral nerve should be carefully identified and handled. Question. What is essential for preventing chronic postoperative pain after inguinal hernia surgery? Answer. Avoiding nerve damage is essential to prevent chronic pain after inguinal hernia surgery. Question. What combination of dissection techniques is used for spermatic cord mobilization, and where are they applied? Answer. A combination of blunt and sharp dissection techniques is used at the pubic tubercle. Question. What risks can result from improper spermatic cord mobilization? Answer. Improper mobilization can cause confusion in identifying tissue planes and essential structures, potentially harming the spermatic cord or disrupting the inguinal canal floor. Question. Where is the spermatic cord located during this step of the operation? Answer. It is located at the pubic tubercle. Question. How is the cremaster muscle dissected from the underlying cord structures? Answer. It is separated from the underlying cord structures parallel to its fibers. Question. What vasculature is associated with the cremaster muscle, and what may be required during dissection? Answer. The cremaster artery and vein are present. They can often be avoided, but they may need to be sacrificed. Question. How should the spermatic cord be managed to reduce the risk of genital branch of the genitofemoral nerve injury? Answer. Minimize disruption to cremasteric fibers and vasculature to reduce the risk of injury to the genital branch of the genitofemoral nerve. Question. What historical practice was previously advocated for handling the spermatic cord? Answer. Skeletonizing the spermatic cord was previously advocated by some surgeons. Question. Where is the hernia sac located relative to the cremaster muscle and spermatic cord structures? Answer. It is deep to the cremaster muscle and anteromedial to the spermatic cord structures. Question. How is the hernia sac exposed during open repair? Answer. Spreading the cremaster muscle longitudinally exposes the hernia sac. Question. How is the hernia sac dissected during open repair? Answer. Carefully separate the hernia sac from the cord structures and dissect it to the internal inguinal ring. Question. When and how should a hernia sac be examined during open repair? Answer. Large hernia sacs are opened and examined for visceral contents. Question. What are the treatment options for a hernia sac during open repair? Answer. The sac can be mobilized and placed within the preperitoneal space or ligated at the internal ring. Question. How may a large hernia sac be managed to facilitate ligation? Answer. Electrocautery may be used for division to facilitate ligation. Question. How should a cord lipoma be treated during open inguinal hernia repair? Answer. Suture ligate and excise the cord lipoma. Question. What is a cord lipoma in the context of inguinal hernia repair? Answer. It is retroperitoneal fat herniated through the deep inguinal ring. Question. Why is a cord lipoma clinically significant? Answer. It can cause recurrence and a persistent postoperative bulge. Question. What is a sliding hernia? Answer. It is a hernia where part of the hernia sac is made up of visceral peritoneum covering a retroperitoneal organ, usually the colon or bladder. Question. How should a sliding hernia be managed during repair? Answer. Excise the redundant portion of the sac without injuring the involved viscera, then close the peritoneal defect and reduce the viscera and sac. Tissue repairs. Question. When are tissue-based repairs indicated for inguinal hernias? Answer. Tissue-based repair is indicated for strangulated hernias requiring bowel resection when synthetic mesh is contraindicated. Question. Which tissue-based repair techniques are commonly described for inguinal hernias? Answer. Commonly described techniques include iliopubic tract repair, Schultes repair, Bassini repair, and McVeigh repair. Question. What are the main limitations of tissue-based inguinal hernia repair? Answer. Tissue-based repairs have higher recurrence rates, which has contributed to decreased usage. Question. How is iliopubic tract repair performed? Answer. Iliopubic tract repair involves approximating the transversus abdominis aponeurotic arch to the iliopubic tract. Question. What suture technique is used for the approximation in iliopubic tract repair? Answer. Interrupted sutures are used for the approximation. Question. Where does iliopubic tract repair typically start and end? Answer. The repair starts at the pubic tubercle and extends laterally beyond the internal inguinal ring. Question. Is a relaxing incision always performed in iliopubic tract repair? Answer. No, it is not always performed, even though it was part of the initial description. Question. Which hernia types are addressed by this tissue repair technique? Answer. This technique addresses direct hernias, large indirect hernias, recurrent hernias, and femoral hernias. Question. What surgical technique is used in this tissue repair, including the femoral hernia modification? Answer. Interrupted non-absorbable sutures are used to approximate the transversus abdominis aponeurosis to Cooper's ligament. For femoral hernia repair, a transition suture incorporates Cooper's ligament and the iliopubic tract. Question. What advantages are described for the McVeigh repair? Answer. It is particularly well suited for addressing strangulated femoral hernias because it obliterates the femoral space without the need for mesh. Question. What is meant by tissue-based hernia repair in this context? Answer. Novel techniques such as the Desarta hernia repair use the patient's own tissues to reinforce the inguinal canal. Question. How is the Desarta technique described for reconstructing the inguinal floor? Answer. It employs a strip of the patient's external oblique aponeurosis to reconstruct the weakened inguinal floor. Question. What is a tension-free anterior inguinal hernia repair? Answer. It is the most common approach to inguinal hernia repair and uses synthetic mesh to bridge the hernia defect. Question. What mesh placement options are listed for tension-free repair? Answer. Options include the Liechtenstein approach, the plug and patch technique, and the sandwich technique. Question. Which type of mesh is preferred for tension-free repair? Answer. Flat mesh is preferred over three-dimensional meshes. Question. How is the Liechtenstein repair described in terms of preparing and positioning the mesh? Answer. In the Liechtenstein repair, a piece of prosthetic non-absorbable non-absorbable mesh is customized to fit the inguinal canal. A slit is made to accommodate the spermatic cord, and a preformed or custom mesh is used. Question: how should the mesh be positioned relative to the pubic tubercle to reduce pain? Answer: the mesh is positioned to avoid direct contact with the pubic tubercle to reduce pain. Question: how is the mesh fixed to the inguinal ligament during a Liechtenstein repair? Answer: the mesh is sutured to the inguinal ligament using non-absorbable sutures, starting near the pubic tubercle. Question: how much should the mesh overlap the pubic tubercle and where is it secured? Answer: the mesh overlaps the pubic tubercle by at least 2 centimeters and is secured to the conjoint tendon. Question: how is a new internal inguinal ring formed with the mesh tails? Answer: the tails of the mesh are sutured together around the spermatic cord to form a new internal inguinal ring. Question: which nerve should be protected to avoid entrapment during this repair? Answer: care is taken to avoid entrapment of the ilioinguinal nerve and iliohypogastric nerve during the repair. Question: what surgical technique is described for placing a self-expanding polypropylene patch in the preperitoneal space? Answer: the technique involves placing a self-expanding polypropylene patch in the preperitoneal space. Question: how is the patch positioned and what spaces does it cover? Answer: the patch expands to cover the direct, indirect, and femoral spaces and lies parallel to the inguinal ligament. Question: how is the patch fixed in place? Answer: the patch can remain in place without sutures, but a tacking suture may be used. Question: how is mesh positioned in the Rives stop repair method? Answer: the mesh is positioned to extend into the space of Retzius, beyond the obturator foramen, and posterolateral to the pelvic brim. Question: what advantages are described for the Rives stop repair method? Answer: this technique evenly distributes intra-abdominal pressure to help maintain proper mesh positioning, and it is especially beneficial for large, recurrent, or bilateral hernias. Question: what surgical approach is described for this technique? Answer: it uses an open preperitoneal approach. Question: which hernia types are listed as indications for this open preperitoneal approach? Answer: indications include recurrent inguinal hernias, sliding hernias, femoral hernias, and select strangulated hernias. Question: what procedure steps are listed for the open preperitoneal approach? Answer: the steps include a transverse skin incision, a muscle incision, identification of the preperitoneal space, optional incision of the anterior rectus sheath, and exposure of the hernia defect. Question: why are the inferior epigastric vessels mentioned in relation to this approach? Answer: they are usually situated beneath the midportion of the posterior rectus sheath, which can minimize manipulation of the spermatic cord and reduce the risk of nerve injury. Question: what is the key suturing component described for this approach? Answer: the key component is identifying and suturing the transversalis fascia and transversus abdominis aponeurosis to the iliopubic tract using permanent sutures. Question: how is a femoral hernia repaired in this approach? Answer: the femoral canal is closed by securing the repair to Cooper's ligament. Operative management. Minimally invasive techniques. Question: which minimally invasive techniques are used for inguinal hernia repair? Answer: minimally invasive techniques include transabdominal preperitoneal repair, totally extraperitoneal repair, and enhanced view totally extraperitoneal repair. Question: how can minimally invasive inguinal hernia repair be performed in terms of operative platform? Answer: it can be performed with traditional laparoscopic surgery or with robotic-assisted laparoscopic surgery. The critical view of the myopectineal orifice. Question: what critical surgical step is essential to minimize complications, minimize recurrence, and ensure adequate dissection? Answer: obtaining the critical view of the myopectineal orifice is essential to minimize complications and recurrence. Question: on what basis was the protocol for the critical view of the myopectineal orifice developed? Answer: it was developed based on evidence demonstrating fewer hernia recurrences and fewer complications. Question: why is obtaining the critical view of the myopectineal orifice important? Answer: obtaining the critical view of the myopectineal orifice is crucial for safe dissection and for ensuring adequate mesh overlap. Question: how should the pubic tubercle be dissected when establishing the critical view of the myopectineal orifice? Answer: dissect the pubic tubercle past the midline. Question: how should Cooper's ligament be identified on the same side as the hernia defect? Answer: identify Cooper's ligament on the same side in relation to the hernia defect. Question: how far should preperitoneal dissection extend to ensure adequate mesh overlap for large direct inguinal hernias? Answer: dissection should extend to the contralateral Cooper's ligament. Question: how should the direct space be identified during the critical view of the myopectineal orifice? Answer: clearly visualize Hasselbalch's triangle and remove adipose tissue within it to identify the direct space and the hernia defect. Question: what spacing should be ensured between Cooper's ligament and the bladder during dissection in the space of Retzius, and why? Answer: ensure at least 2 centimeters between Cooper's ligament and the bladder to prevent mesh dislodgement or folding, a problem commonly referred to as mesh clamshelling. Question: what dissection is performed to identify the femoral orifice and rule out a femoral hernia? Answer: dissect between the external iliac vein and Cooper's ligament to identify the femoral orifice and rule out a femoral hernia. Question: what dissection is performed around the gonadal vessels and vas deferens during indirect sac management? Answer: dissect the indirect sac and peritoneum off the gonadal vessels and the vas deferens. Question: why is parietalization of the gonadal vessels and vas deferens important for mesh placement? Answer: parietalization ensures proper placement of the inferior border of the mesh. Question: what should be observed when applying traction to the hernia sac and peritoneum regarding cord elements? Answer: traction on the hernia sac and peritoneum should not cause movement of the cord elements. Question: how should cord lipomas be identified and managed during minimally invasive repair? Answer: cord lipomas, usually lateral to the cord elements, should be identified and reduced, and large lipomas may require excision. Question: how far should the preperitoneal space be dissected laterally, and what is the goal of this dissection? Answer: dissect laterally beyond the anterior superior iliac spine so that the peritoneal reflection lies inferior to the mesh. Question: what mesh size and positioning characteristics are recommended to adequately cover the myopectineal orifice? Answer: use a mesh that is at least 10 centimeters by 15 centimeters, ensuring it covers the myopectineal orifice adequately and lies flat without creases. Question: where should fixation points be placed to prevent recurrence and nerve injury? Answer: place fixation points above the line between the anterior superior iliac spine and the internal inguinal ring. Question: what should be done during deflation to ensure the mesh does not fold? Answer: while releasing Increasing pneumoperitoneum. Observe the mesh and ensure it remains flat and properly positioned as the preperitoneal space deflates. Transabdominal preperitoneal inguinal hernia repair question. What is the surgical approach used in transabdominal preperitoneal inguinal hernia repair? Answer. Transabdominal preperitoneal repair is the most common minimally invasive approach for inguinal hernia repair. Question. How are ports placed for transabdominal preperitoneal inguinal hernia repair? Answer. A camera port is placed in the midline, and 2 working ports are placed laterally. Question. Why is the peritoneal flap closed in transabdominal preperitoneal inguinal hernia repair? Answer. The peritoneal flap is closed to cover the mesh, preventing adhesions and dislodgement. Total extraperitoneal inguinal hernia repair question. What is total extraperitoneal repair? Answer. Total extraperitoneal repair is a minimally invasive inguinal hernia mesh repair technique. Question. What access route is used in total extraperitoneal repair? Answer. It involves accessing the preperitoneal space through an anterior approach without entering the peritoneal cavity. Question. What are the procedure steps and port placement in total extraperitoneal repair? Answer. The procedure begins with retrorectus access, followed by widening the retromuscular and preperitoneal space for mesh placement. It is a laparoscopic inguinal hernia repair using mesh. Port placement uses a Hassan cannula for insufflation and 2 additional 5 mm ports along the midline. Mesh is placed after achieving the critical view of the myopectineal orifice, and the preperitoneal space is deflated to ensure stable positioning. Enhanced view totally extraperitoneal inguinal hernia repair question. What is the goal of the enhanced view totally extraperitoneal approach? Answer. The goal is to improve the operative field for the extraperitoneal approach. Question. What innovation defines the enhanced view totally extraperitoneal approach? Answer. It involves division of the medial or lateral aspect of the arcuate line to increase the preperitoneal space. Question. When did the enhanced view totally extraperitoneal approach evolve, and why was it developed? Answer. It evolved from the total extraperitoneal approach in 2009 to address ergonomic challenges. Question. Why is preventing a peritoneal breach important during extraperitoneal approaches? Answer. Preventing holes in the peritoneum is critical to avoid carbon dioxide escape and maintain the working space. Question. How should a peritoneal breach be managed during an extraperitoneal approach? Answer. Control breaches with clips or sutures, or consider an additional intraperitoneal port for venting. Question. When may conversion to a transabdominal approach be necessary? Answer. If the preperitoneal space cannot be maintained, conversion to a transabdominal approach may be necessary. Selection of operative technique question. What factors determine selection of a surgical technique for inguinal hernia repair? Answer. Selection is tailored to patient and hernia characteristics, the surgeon's experience and preferences, and available resources. Question. What skills are required for comprehensive inguinal hernia treatment? Answer. Comprehensive treatment requires proficiency in both anterior and posterior approaches, mesh and non-mesh repairs, and open and minimally invasive techniques. Question. What is the recommendation for mesh repair in adult inguinal hernias? Answer. Mesh-based repair is recommended for adult inguinal hernias, and the flat mesh Liechtenstein technique is favored over 3-dimensional implants. Question. What is the recommendation for non-mesh repair? Answer. For non-mesh repairs, the Schultes technique is recommended. There has also been a shift toward minimally invasive surgery techniques because they offer advantages such as decreased post-operative and chronic pain and a faster return to normal activity. Question. Which repair techniques are preferred for bilateral inguinal hernias, femoral hernias, and primary unilateral groin hernias in males? Answer. Minimally invasive techniques, specifically total extraperitoneal repair or transabdominal preperitoneal repair, are preferred for bilateral inguinal hernias, femoral hernias, and primary unilateral groin hernias in males. Question. What is the current role of open repair? Answer. Open repairs can be successful in experienced hands, but they are becoming less favored. Question. What are the contraindications for a minimally invasive approach? Answer. Contraindications include inability to tolerate general anesthesia and a significant surgical history in the lower abdomen. Common post-operative complications: seromas and hematomas. Question. What is the perioperative complication rate for inguinal hernia repair? Answer. It ranges from 5% to 10%. Question. What are seromas and hematomas after inguinal hernia repair? Answer. They are fluid or blood collections in the dead space after repair. Question. What is the role of drain use after inguinal hernia repair? Answer. Closed suction drainage reduces scrotal edema, seroma formation, and urinary retention. Question. When is drain placement used after inguinal hernia repair? Answer. It is not routinely used and is reserved for complex or large inguinal hernias. Question. How are seromas managed after inguinal hernia repair? Answer. Most small seromas can be managed conservatively, while larger or persistent seromas may require aspiration or surgical excision. Question. How are hematomas managed after inguinal hernia repair? Answer. Large hematomas should be evacuated to reduce discomfort and healing time, and urgent exploration is required for acute postoperative hematomas with active bleeding or hemodynamic changes. Surgical site infection. Question. What is the surgical site infection rate in unilateral initial open inguinal hernia repairs? Answer. It is 0.4% in unilateral initial open hernia repairs. Question. What are the risk factors for surgical site infection after inguinal hernia repair? Answer. Risk factors include diabetes, a body mass index greater than 35 kilograms per square meter, and current smoking. Question. How does the surgical site infection rate compare between open repair and total extraperitoneal repair? Answer. Open repair has a higher infection rate, at 4.6%, compared with 2.2% for total extraperitoneal repair. Question. What is the recommendation for antibiotic prophylaxis in inguinal hernia repair? Answer. Antibiotic prophylaxis is not recommended in low-risk environments, but it may provide benefit in high-risk environments and is recommended only in those settings. Question. How are superficial and deep surgical site infections managed after inguinal hernia repair? Answer. Superficial skin infections are managed conservatively with antibiotics or incision and drainage. Unsuccessful conservative treatment suggests a deep infection, potentially involving mesh, and surgical exploration with debridement may be necessary. Mesh infection. Question. How common is mesh infection after abdominal hernia repair? Answer. It is estimated to occur in 1% to 4% of abdominal hernia repairs. Question. What symptoms can suggest mesh infection? Answer. Symptoms may be indolent and include swelling, swelling, pain, draining sinus tracts, or masses, often without obvious skin inflammation. Question: how is mesh infection diagnosed? Answer: diagnosis is primarily based on clinical presentation, but imaging such as ultrasound and computed tomography scans can be helpful. Question: is surgical removal usually necessary for inguinal mesh infection? Answer: yes. Surgical removal is almost always necessary for inguinal mesh infection. Question: when should infected mesh usually be removed? Answer: removal is usually performed at least 3 months after symptom onset to allow tissue incorporation and separation of infected mesh. Question: which surgical approach is typically used for mesh removal? Answer: the mesh is typically removed using the same surgical technique as the initial placement, with laparoscopic removal for transabdominal preperitoneal repair or total extraperitoneal repair and open removal for open repair. Question: when may a laparoscopic approach be considered after an open repair? Answer: a laparoscopic approach may be considered if the open repair involves penetration of the peritoneum or the presence of a sinus so the abdominal cavity can be visualized. Question: how does complete mesh removal compare with partial mesh removal? Answer: complete removal is associated with lower infection recurrence than partial removal. Question: can infected mesh be replaced after explantation? Answer: no. Replacing infected mesh is contraindicated after explantation. Question: how common is hernia recurrence after infected mesh removal? Answer: hernia recurrence is uncommon after infected mesh removal because of the inflammatory reaction. Post-operative urinary retention. Question: what is the incidence of post-operative urinary retention? Answer: the incidence is highly variable, ranging from 0.4% to 41.6%. Question: what was the incidence of post-operative urinary retention in a large study? Answer: in a large international multicenter prospective cohort study involving 4,151 adults across 32 countries, the incidence was 5.8% in males, 3.0% in females, and 9.5% in males aged 65 years and older. Question: what are the risk factors for post-operative urinary retention? Answer: risk factors include anticholinergic medication, a history of prior urinary retention, constipation, bladder involvement in the hernia, temporary intraoperative urethral catheterization, longer operative times, and increasing age. Question: how is post-operative urinary retention treated? Answer: treatment is conservative. Common management is indwelling ureteral catheterization, less common management is intermittent catheterization, and rarer management is suprapubic catheterization. Question: how important is post-operative urinary retention as a complication after inguinal hernia repair? Answer: post-operative urinary retention is a common complication and accounted for the majority of 30-day readmissions in the Retainer Eye trial. A significant percentage of patients admitted for post-operative urinary retention required catheterization, although most could void spontaneously by 30 days, and unplanned admissions and readmissions still occurred in a small percentage of patients. Question: how do neuromuscular blockade agents and dexamethasone affect post-operative urinary retention? Answer: Sugamidex, a newer neuromuscular blockade agent, was associated with a 66% reduction in 30-day post-operative urinary retention compared with traditional anticholinestase agents. Perioperative administration of dexamethasone was independently associated with decreased urinary retention. Hernia recurrences. Question: what is the recurrence rate for inguinal hernias after repair? Answer: inguinal hernia recurrences occur in 5% to 10% of patients. Question: what are the risk factors for inguinal hernia recurrence? Answer: risk factors include chronically elevated intra-abdominal pressure, impaired wound healing, recurrent hernia repairs, and direct hernias. Question: how is recurrent inguinal hernia repair typically approached? Answer: recurrent repair is typically performed from the opposite side of the initial repair to avoid the failed surgical plane. Chronic groin pain. Question: how common is chronic groin pain after inguinal hernia repairs? Answer: chronic groin pain affects 10% of patients after inguinal hernia repairs, with 2% to 4% experiencing pain that disrupts daily activities. Question: when is chronic post-operative pain generally diagnosed, and when is urgent re-exploration needed? Answer: a 3-month waiting period after surgery is generally recommended before diagnosing chronic post-operative pain, except in cases of severe new onset pain suggesting nerve entrapment, which requires prompt re-exploration. Question: how is mesh fixation related to chronic groin pain? Answer: chronic pain is associated with penetrating mesh fixation. A randomized controlled trial from 2023 found similar recurrence rates with less acute and chronic pain when mesh was not fixed compared with fixation using tacks. Question: what are the risk factors for chronic post-operative pain after inguinal hernia repair? Answer: risk factors include bilateral inguinal hernia repair, preoperative pain, preoperative anxiety, and relatively high intensity of acute pain during the first post-operative week. Question: which nerves are at risk in chronic groin pain after inguinal hernia repair? Answer: nerves at risk include the lateral femoral cutaneous nerve, the genital branch of the genitofemoral nerve, and the femoral branch of the genitofemoral nerve. Question: how is chronic groin pain managed after inguinal hernia repair? Answer: management begins conservatively with medications and nerve blocks, followed by surgical exploration if necessary. Question: why is a multidisciplinary approach important in chronic groin pain management? Answer: chronic groin pain management can be complex and time-consuming, so a collaborative multidisciplinary approach is important. Special consideration: sliding hernias. Question: what is a sliding hernia? Answer: a sliding hernia occurs when a retroperitoneal organ slides down and herniates, becoming part of the hernia sac. Question: how common are sliding hernias, and who is at increased risk? Answer: sliding hernias account for 13.5% of hernias, with increasing risk in older adults. Question: what surgical considerations are important in sliding hernia repair? Answer: sliding hernias require careful repair to avoid injuring the involved organ, which may include the cecum, colon, appendix, uterus, or bladder. A thick sac wall should be confirmed not to be the wall of a retroperitoneal organ involved in the hernia. Sliding hernias may also carry a potentially higher recurrence risk, especially after open Liechtenstein repairs. Question: how is the redundant sac managed in sliding hernia repair? Answer: the redundant sac is excised in open repair and reduced in laparoscopic repair after content reduction. Scrotal hernias. Loss of domain. Question: what is the definition of a giant inguinal hernia? Answer: a giant inguinal hernia is a hernia that extends past the midpoint of the inner thigh in a standing position. Question. What are the risk factors for scrotal hernias and loss of domain? Answer. Risk factors are similar to recurrence risk factors, including conditions that increase intra-abdominal pressure or impair wound healing. Question. What surgical considerations are important in scrotal hernias and loss of domain? Answer. Open repairs are typically preferred, with preoperative efforts to decrease hernia sac bulk and careful patient selection because of the potential for respiratory failure and other complications. Inguinal groin pain. As a chief complaint workup question. What does the workup for chronic groin pain include? Answer. The workup includes a comprehensive history, physical examination, and review of prior radiographic studies. Question. What is the SPORT framework used for in investigating chronic groin pain? Answer. It is a helpful framework for investigating the source of chronic groin pain. Question. What pain history details should be obtained during workup for chronic groin pain? Answer. Important details include onset, quality, radiation patterns, prior medical therapies, location, frequency, exacerbating factors, alleviating factors, severity, and mental health history. Question. What information from the operative report is useful in the workup of chronic groin pain? Answer. Useful operative report details include the type of mesh used, any identified nerves, and any intraoperative or perioperative complications. Question. What conditions should be included in the differential diagnosis of chronic groin pain? Answer. The differential diagnosis includes mesh complications, nerve entrapment, hernias, lipomas, endometriosis, osteitis, intra-abdominal pathology, back or spine issues, hip joint problems, musculoskeletal issues, and psychosomatic or psychological factors. Question. How can neuropathic pain be differentiated from nociceptive pain in chronic groin pain assessment? Answer. Neuropathic pain often presents as a large, widespread area, whereas nociceptive pain is usually more localized. Pain mapping can help, using a simple 1 for areas of pain and 0 for areas without pain. Question. Which imaging modalities are used for hernia evaluation in chronic groin pain workup? Answer. Imaging options include dynamic sonograms, computed tomography scans, magnetic resonance imaging, and diagnostic laparoscopy. In a dynamic sonogram, the ultrasound probe is placed at the point of pain while the patient stands still and performs the Valsalva maneuver. Dynamic sonograms are cost-effective but depend on technician skill, so computed tomography or magnetic resonance imaging is preferred if the sonogram is inconclusive. Treatment question. What is the general treatment approach for chronic groin pain? Answer. Treatment is stepwise and tailored, similar to other chronic pain treatments. Question. Which non-invasive techniques can provide relief for chronic groin pain? Answer. Rest, ice, heat, and over-the-counter anti-inflammatory medication can provide relief. Question. When is pain specialist referral helpful in chronic groin pain management? Answer. Referral is helpful for non-operative workup and treatment. Question. What options are available if conservative therapy fails? Answer. More aggressive pain management techniques are available if conservative therapy fails. Question. How is neuropathic pain managed in chronic groin pain? Answer. Gamma-aminobutyric acid modulators such as gabapentin may help, but narcotics should be avoided initially. Question. What is the role of nerve blocks and neurectomy in chronic groin pain treatment? Answer. Nerve blocks offer temporary relief, while neurectomy may be beneficial for sustained pain control. Question. What is the success rate of surgical treatment for chronic groin pain? Answer. Surgical treatment has about a 70% pain-free success rate. Question. What factors influence the choice and course of surgical treatment for chronic groin pain? Answer. Important factors include the patient's history, the etiology of pain, and the potential need for multiple interventions. Question. What outcomes should patients be counseled about after surgical treatment for chronic groin pain? Answer. Patients should be counseled that 30% may experience persistent chronic pain or discomfort. Surgical evaluation and mesh explantation. Question. How is laparoscopy used in the surgical evaluation of chronic groin pain? Answer. Laparoscopy is helpful in diagnosing and treating groin pain, especially in patients with a history of surgery. It can identify adhesions, hernias, and mesh-related issues contributing to pain. Question. What is the role of preoperative and postoperative pain mapping? Answer. Preoperative and postoperative pain mapping helps evaluate the effectiveness of the intervention. The goal of the procedure is to eliminate groin pain by addressing nerve issues or hernias. Question. What is triple neurectomy and when is it used? Answer. Triple neurectomy is a surgical procedure targeting the ilioinguinal, iliohypogastric, and genitofemoral nerves to alleviate persistent postoperative neuropathic groin pain. If a hernia is present, the goal is to provide a durable repair. Question. What approach should be used for mesh removal, and what outcome can be expected? Answer. Mesh removal should use the same surgical approach as the initial mesh implantation. Mesh removal may not always resolve chronic pain after hernia repair, although it can improve foreign body sensation and neuropathic pain in some patients. Question. Why is mental health evaluation important in patients with chronic groin pain? Answer. Mental health can contribute to the onset of chronic pain and may also be affected by the experience of chronic pain. Post-traumatic stress, anxiety, depression, and suicidal ideation have been reported in patients with chronic pain, so it is crucial to assess and document mental health status to provide comprehensive care. Sports hernias and athletic pubalgia. Question. What is sports hernia and athletic pubalgia? Answer. It is a groin pain syndrome affecting athletes, especially those in high-impact sports, involving the abdominal wall, tendons, pelvis, and inguinal ligament. Question. What symptoms are seen in sports hernia and athletic pubalgia, and how does it differ from a typical hernia? Answer. Symptoms include pain around the pubic tubercle, which may extend to the adductor longus tendon or rectus abdominis insertion points, and the pain worsens with sprinting or twisting movements. Unlike typical hernias, sports hernias do not present with a bulge. Question. What are the physical examination findings and preferred imaging studies for sports hernia and athletic pubalgia? Answer. Physical examination findings include point tenderness at the external ring and pubic tubercle, and pain with forced adduction in a frog-like position. Magnetic resonance imaging is the preferred imaging study to differentiate sports hernia from hip joint pathology, and ultrasound with the Valsalva maneuver is used to rule out inguinal hernias. Question: what is the differential diagnosis, and how is sports hernia and athletic pubalgia treated conservatively? Answer: it is important to differentiate sports hernia from adductor muscle injury, which is managed with physical therapy. Conservative treatment includes ice packs, anti-inflammatory medications, rest, and rehabilitation. Question: what are the roles of surgical treatment and physical therapy in sports hernia and athletic pubalgia? Answer: surgical treatment reduces tension and torque on the pubic joint and decompresses inguinal sensory nerves, often with suture or mesh reinforcement. Physical therapy can provide outcomes similar to surgery, but it may not be preferred by athletes who are eager to return to sports. Question: what are the standard repair techniques, and how do open and laparoscopic approaches compare? Answer: standard repair techniques include laparoscopic pre-peritoneal repair or open anterior repair with synthetic mesh. Open techniques allow better identification of abnormalities and more precise anatomy, whereas laparoscopic repair offers less pain in the first month and a sooner return to activity. Question: what are the key features of the open repair procedure? Mesh considerations, adductor longus tenotomy, complications, and post-operative care? Answer: open repair involves an incision slightly below typical open inguinal hernia repairs to visualize tendon insertion points and use various techniques to reinforce the inguinal floor. Mesh can reduce tension but carries risks of infection and pain. Adductor longus tenotomy can be performed concurrently to alter the pulling vector on the pubic bone, potentially relieving pressure on the adductor compartment and obturator nerve. Repair complications are uncommon, and post-operative physical therapy is recommended. That's it. Thanks for tuning in. If you enjoy our content, please like, share, and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.